all of you for being here and supporting Wine and Dine in the D. It's very, very important. We couldn't do any of this without you. I also want to thank our sponsors on this. I'm not going to mention you all, but thank you so much for doing this. It's very, very important. And now I'm going to quickly try and introduce our wonderful, esteemed panel of doctors here. Because nobody else would do this, so I'm going to try and do it myself. Dr. Craig Emmett, alphabetical order. Dr. Craig Emmett Cole. He is a long title. Assistant Professor, Director of Clinical Trials, Program Hematology Oncology, MSU College of Human Medicine, Karmanos Cancer Institute, McLaren, Greater Lansing.
Excellent.
Dr. Philip Caracosi. Behind me. Yeah, I know. That would be bad. Oh, here. Thanks. Dr. Caracosi is Chief Section of Hematology, Clinical Associate Professor, Lymphoma and Plasma Cell Disorders Group, Henry Ford Cancer Institute, Henry Ford Health. Dr. Jeffrey Margolis, Hematologist and Oncologist, President of Michigan Healthcare Professionals, PC, and Professor of Oncology at Oakland University, William Beaumont School of Medicine. George Mulligan, PhD, Chief Scientific Officer of the Multiple Myeloma Research Foundation. Matthew Pianco, Clinical Assistant Professor of Internal Medicine, Division of Hematology Oncology, Rogel Cancer Center, University of Michigan Medical School. Dr. Joseph Uberti, Professor of Medicine and Oncology, Director, Blood Marrow Stem Cell Transplant Program, Lambert Weber Endowed Chair of Stem Cell Research, Barbara Ann Karmanos Cancer Institute, Wayne State University. And Dr. Jean Christine Yee, who traveled the farthest, Associate Professor, Department of Lymphoma and Myeloma, MD Anderson Cancer Center, Houston, Texas. So welcome, all of you. Thank you so much for taking the time to do this. And I'm going to turn it over to Dr. Margolis to kick things off, and I'm leaving here.
Terrific. So what we'll do is, if most of you have been here before, we'll kind of keep the format as questions from the audience, and our esteemed panel will answer the questions as best as they can. If one person can't do it, they can pass the mic to another person, or if there's different perspective, we may get 2 or 3 people to answer the same question. So we'll make sure that this is an audience participation piece, and you guys are just as responsible for getting this thing to work as we are up here, because it's your questions that really make this whole symposium work. And then to get the big elephant out of the room, tonight we will call in the Lions score in each quarter, so you don't have to worry about missing it. All right. So one of the reasons we put this whole thing together is to raise money for research. And I think it's probably worthwhile just to get an idea of what kind of research we're doing and what your money's doing for research. So George, if you could kind of kick off and tell us what we're doing with in the research setting of myeloma.
Thanks. Yeah, hi everyone. We really appreciate you coming out to participate with us. So I tend to think, and this is one person's view, I tend to think of there really being 3 legs to the stool when it comes to research. And the most important part is it starts with patients and the doctors that they work with, who are really caring for those patients and helping to understand the disease, treat the disease, and often they are able to work with patients and enter them into clinical trials, which advance our scientific understanding of the disease. A really important second leg I think of is the translational research that comes from studying how patients do on those clinical trials. And this is a really critical area to understand better about what the drugs or drug combinations are doing, and to better understand their potential fit with patients, what might lead to particularly good outcomes, what may indicate that patients aren't going to do so well. and potentially understand some of the toxicities as well. So there's an enormous amount of translational research that goes on in the labs of our major hospitals and academic centers, and also goes on at centers that are like ours at the MMRF, who work in partnership with all of the major academic centers in the U.S. And a really important third leg, I think, of is the entire biopharma industry, where some of their basic research translates into new opportunities to bring drugs into the clinic. And that's a very deep funnel. I spent a lot of my career working in different companies, trying to develop drugs that were specific to certain cancers. And there are many ideas that fail, and then some of them are brought into the clinic to ultimately see how they do with patients. And so working with these companies, I think, is really an essential part of what we all do to, again, bring new drugs back into the setting of testing in patients and working with patients in clinical trials. So the research always starts with patients, and in that circle that I've described, it really ends with patients. So I just want to thank you for your participation in this sort of an event, and we're happy to share and hear about your questions, and get some of the perspective of the panel.
Terrific. I'm going to just ask, broaden this up to some other people in the panel. Christine, how do you think about clinical trials at MD Anderson, and how do you see that incorporating into your practice?
Yeah, certainly I feel like the clinical research did not start just when I started at MD Anderson. Actually, it started when I did my fellowship with Dr. Uberti at Wayne State Carmano's Cancer Institute, and certainly further developed when I was working at University of Michigan. And I also learned from my colleagues, Craig and also Matt, when we were working together. Furthermore, like MD Anderson is a big institute that, because it's a cancer hospital, certainly has a rich resource for clinical research. But I think the principle is quite similar among different institutions. As Dr. Mulligan just mentioned, that we try to bring those drugs from the lab to the bedside in the clinic. But this is a long journey. This is not something that you are able to expect over the course of weeks or months. This is years of development. And as a clinician, we've been actively involved in those clinical research. So in addition to the current like so-called standard of care regimens, we're trying to see whether or not those novel agents can be incorporated into the existing regimens or treatment therapy plans, so that the gold standard called overall survival for patients, especially for our multiple myeloma patients in the audience here, that we can make this longer and longer. So we have long-term goal, hopefully to cure. I am not sure yet, but I think the statistic data that has shown that in the last few decades, the overall survival for myeloma patients has doubled, and we hope that it can triple and even longer.
Greg, if you want to talk a little bit about how you see clinical trials incorporating into your practice, and when do you use clinical trials?
My practice basically is the fruit of all the clinical trials. I mean, what has happened in myeloma is unprecedented. I mean, we had 2 drugs that were, in fact, it was funny because I was driving in today, and it's the first time I've been here since COVID. And I remember I was thinking about melflufen, which was a drug, which was the hot drug in 2019. And now that drug has gone to the side, and now we have 2 new drugs that were approved within 7 days of each other for multiple myeloma. That is unprecedented of cancer, to have 2 drugs approved within 7 days of each other. And that then translates into my clinic, where I can actually use those drugs, and my colleagues can use those drugs that weren't available, for general practice just a few days before that. So now we're always looking for the next thing. So we ask, what clinical trials can we be involved with to push that needle further? because I think that we have already cured some people with myeloma. We need to be able to try and cure everyone with myeloma. And the way to do that is to keep enrolling in clinical trials and finding the different types of myeloma, because it's myelomas, not myeloma. Everyone's different with this disease. Finding out the best treatment for individual patients to be able to apply that and to have them have the best lives that they can have. So in doing clinical trials, being involved in clinical trials, institutions involved in clinical trials is how you get there.
Matt, same question to you.
Like my colleagues, I think clinical research is really essential to what we do. Many of these options we have in the clinic came right from clinical research, as Craig said, and it's really been an amazing thing to be a part of, to see new drugs come into use and to work with patients who are trying new drugs and to see them get some benefits from these drugs. And hopefully we continue to have a rich pipeline of new things coming along that can extend people's lives and improve their quality of life, both goals being essential. So I think in general, clinical research, I think we have clinical trials, and think about clinical trials for myeloma patients from the time of diagnosis, from the time of their first relapse and times of subsequent relapses. And I think clinical trials offer an opportunity to possibly get access to drugs that they may not otherwise be able to get access to that might help them. In some ways, I often have discussions with my patients that we're thinking about a treatment change for their myeloma. We're looking through a menu of options at a restaurant. And if our goal is to be at this restaurant as long as possible and to try as many options as we can to really enjoy the restaurant, the standard of care options that came from clinical trials that are approved are like those things that end up printed on the menu, that are kind of the permanent, tried and true dishes that are really good at the restaurant. Clinical trials, they come and go. They're options that don't, have a long life. They're in terms of just like what drugs that work or don't. The clinical trials can be a lot like specials. There can be a new ingredient that comes along it's a really good one, and if it does well in the specials, maybe it'll end up being a permanent option on the menu. So this discussion, I often have the patients say, we may not know if the special is a good dish, but I think that if you try it and it's a good dish, it might help. There's some unknowns, but there are also some unknowns with what's on the menu too. So I think trying to help people navigate this discussion of what's known and what's not known is one of the joys and challenges of practicing and taking care of patients with myeloma. But I think really having access to clinical trials really broadens everyone's reach, and it's been great, kind of learning from not only the trials that we participate in that are led by pharmaceutical company partners who spend and invest a lot of time and energy into bringing these drugs to patients, but also looking at clinical research concepts that are developed that have really interesting scientific questions that are asked. And the MMRC and the Multiple Myeloma Research Foundation leads many of those trials to try to maybe pick treatments based on a certain person's myeloma type, or to other types of trials, including one led by like Dr. Yi, looking at trying to change our treatment plan based on how deep patients respond to their initial myeloma treatment. So I think there's lots of interesting questions that can be developed, new drugs, new approaches, and I kind of see it woven into all aspects of what we do.
Phil, why don't you have a crack at the same question?
The advantage of coming close to last is you can say ditto, but just as Matt and Craig and Christine and George were mentioning, clinical trials actually sits, I believe, in the sort of guiding chair of our ship, because that's how everything started. If I look back to the time when I was first treating myeloma with VAD and melphalan and prednisone, all the way 2.5, 3 decades later to now, in the last few days, discussing with patients, newly diagnosed and those who had a first relapse, about the menu list, as Matt was mentioning, of options that are there. What still takes the pride of place in that list is the clinical trial, because we've never reached home till we have. And no matter how good a regimen might be in achieving good remission, either at diagnosis or at relapse, it never should be a slam dunk till you surely have achieved cure with the least amount of therapy and the least amount of toxicity. That in the end remains and should remain our goal. And in that I think there are many studies right now looking at those options. Can we stop therapy sooner than later? And if we can, who are those individuals? That's going to be very important so that we tailor treatment based on need. And then, are two peas truly the same when they're in the same pod? The answer is not necessarily. We know that based on ratio or other sort of backdrops, we all come with our differences. And therefore, not necessarily should we all be given the same shirt to wear. And those sort of thought processes can take us a long way in crafting the right trial and having the right study for our patients. And last but not least, it remains a great venue for education as residents, interns, residents, and fellows go through training. Being a part of clinical trials sets the stage to embed their fertile minds with evolving knowledge that will make life better tomorrow for us than it is today.
I haven't forgotten about you, Joe. So what I want to know from you is, how has clinical trials impacted bone marrow transplant, and where does that fall into this whole piece, or the clinical trials that are part of transplant?
Certainly, it's been a big role in all the therapy we give to patients with multiple myeloma and every type of cancer. You know, part of our mission is to do research. Part of our mission is to teach. Part of our mission is to train new people to do these clinical trials. And I'm sitting between two of them I've helped train in the past, Dr. Cole and Dr. Yin. I'm very happy to see that they've gone much farther than I have in my career, and I'm happy to see both of you doing so well. So we now have a lot of cellular therapy available for patients with multiple myeloma. Not only do we have stem cell transplant, which we've had available for 30 to 40 years now, but now we have CAR T-cell therapy, which is rapidly becoming one of the most common things we do. I was just looking at our numbers here at Carmano's Cancer Center, and this year we're probably going to do 60 CAR T-cell infusions this year alone, and probably a third of those are for multiple myeloma. So CAR T-cell therapy has been one of the things that have come out of investigator-initiated trials that have really been one of the wonderful new therapies we've now used in patients with multiple myeloma. And seeing all of our myeloma patients out there, seeing how long they've lived, we will continue to have them have new therapies available to them as we go on. And sometimes, like Dr. Pianco was saying, it's a menu. What do we do as a first course? What do we do as a second course? What do we do as a third course? We haven't quite sorted that out yet because there are a number of therapies now that target the same sort of molecules in multiple myeloma. And what do we use first? What do we use second? What do we use third? That's a little bit more difficult, and that's something we need to do some more research in. But there are so many cellular therapy availabilities now for patients with multiple myeloma. You know, one of the things that people often ask me, and that was asked last year, how old can you be to get some of these cellular therapies, which sometimes require hospitalization, sometimes are a little more intense. But right now, we easily go past patients who are 80 years of age with some of these cellular therapies. And even things like CAR T cells could be administered to patients safely now. Sometimes we could do this as outpatients. Sometimes we could do this, and remissions are remain for a long period of time. I think they were talking about Dr. Yee looking at minimal residual disease. We've had some people who've had CAR T cell therapy now are 3 and 4 years out who have no MRD marker in their bone marrow, which is quite a fantastic thing. And these are patients who failed 3 to 4 therapies. Now, and this is all from the research we do. There have been clinical trials that we participated in to show that these are very effective therapies. And without the work of clinical trials, we would never be able to have these therapies here with us. So that's really the important thing, having things for patients. Although we don't cure myeloma yet, we will get there. And people are living longer and longer. What I always tell my patients, we need to keep you in remission, and we need to keep a disease under control as long as we can until we do find a cure. And so now we have many, many options all through the research that everyone on this panel talked about that helped us get through this. So that's really what we're doing here with clinical trials. We are having patients live longer. Every year we get closer and closer to a cure. What Craig was saying, having all these new drugs available for multiple myeloma in 1 week is really fantastic. 2 new drugs became available, targeting different antigens on multiple myeloma. The bifunctional antibodies are quite unique that some of the other colleagues will talk about. And they target some of the same things that CAR T cells target. So it's really going to be interesting how we use these. What comes first? What comes second? How we judge what patients will be better on one therapy versus another therapy. That's what we've yet to sort out. But that's one of the things that clinical trials helps us do. So really, it's never a good time to have any cancer, but boy, is there a lot of good therapy for patients with multiple myeloma right now. And every year it seems like we do better and better finding better therapies. And it all comes through clinical trials.
Terrific. I think one of the things that you mentioned, and I think not sure everyone in the audience knows what it is. What is cellular therapy? What is CAR T-cell therapy?
So cellular therapy, so the CAR T-cell therapy is the most recently advanced in cellular therapy. And it's only, we've just scratched the surface of this. So we take a patient's lymphocytes, so a patient who has multiple myeloma, and then we could put inside their lymphocytes a piece of DNA that targets their cells to kill off myeloma cells. So we can manufacture your lymphocytes into cells that can kill myeloma cells. And that takes about 3 to 4 weeks to manufacture these cells. So we send it off to one of the companies. They send, after an apheresis procedure, we send your cells off to a company. The company inserts this viral particle into your cell. It gets incorporated into the DNA of your cell, and it teaches your cell to kill off myeloma cells. Now, those cells are sent back to us frozen, and then we could give it to the patient. And what you do when you give this to a patient, there's some mild chemotherapy we give for 3 days before the infusion of those cells, and then we infuse the cells in and let them do their havoc in killing off myeloma cells. The cells go in, they bind to a myeloma cell, they kill off the myeloma cell, and what the unique thing of that cell is it starts replicating. So more and more cells are built in this little army of cells that can kill off myeloma. So it's really a fantastic strategy. It takes some work, both on our part, the patient's part, and the manufacturing part to build these cells, but it's really been a tremendous benefit to many patients with myeloma. There are some unique toxicities that are involved in getting CAR T cells, but we've been able to find ways to treat and prevent those toxicities and sometimes help those toxicities resolve quite quickly. Now, to get CAR T cells, the way the FDA approval process has gone is you have to fail 4 therapies. So it's a proteasome inhibitor, immunomodulatory drug, a compound that blocks CD38, plus something else. So you have to fail 4 therapies until you're ready or allowed to receive FDA-approved CAR T-cell therapy for multiple myeloma. And there are 2 that are now available, and there may be more coming on down the line. Hopefully, as we go on further, they'll be moved up further in the course of therapy for multiple myeloma. But it's just one of the many advances that have been brought to us from all the research that we're capable of doing to find new ways to treat multiple myeloma.
Hopefully we've stimulated some thought, so I'm hoping we can get some questions from the audience.
Dr. Cole brought up. Hello. Dr. Cole brought up 2 drugs that came about in the same week. The last week of August, I saw on the news where there was another myeloma drug. Was that part of the drugs that you were speaking of?
Yes. Yeah. So the 2 drugs to kind of dovetail of what Joe said is that in CAR T, they reprogram those T cells to find the myeloma cells and kill it. These new drugs are called bispecific antibodies. And so what that means is that usually an antibody are these proteins that are made that are shaped like a Y, and both sticky ends will attach to bacteria, can attach to about anything, and gets the immune system to descend upon it. Incredibly, they've designed a bispecific antibody where one sticky end is towards a T cell, the other sticky end is towards a myeloma cell. So instead of programming the T cells to find the myeloma cells, the bispecific antibodies force the T cells in absolute close proximity to the myeloma cell, and then they duke it out. I mean, they go to war with each other because they're forced in proximity. Before, the T cells were ignoring the myeloma because our T cells are our cancer hunting cells. I mean, the reason that people get cancer is sometimes the T cells can't find the cancer cells. And what the bispecific antibodies do is bring those T cells right up to the cancer cell, the myeloma cell specifically, and then destroy it. And with the CAR T, the target, the sticky part for the myeloma cells called BCMA. And that was a drug that was approved in October of last year, almost a year ago. And then there was another BCMA antibody that was approved, and importantly, a bispecific antibody that targets not just BCMA on myeloma cells, but targets a GPCR5. If I got all those letters right. Did I say it? They need to come up with a better name for that, seriously. Because my kids think I'm like having a seizure when I say that. And there was another antigen on myeloma cells, which attacks it and brings those T cells again. And one that brings the myeloma cell looking at it a different way. And the really exciting thing was at the last ASCO meeting, the big oncology meeting in the United States, when they combined these two drugs together, and the response rates were 85, 90% for people that were really sick with myeloma. And in my lifetime, if you would have thought that I would see CAR-T or bispecifics that for relapse refractory myeloma, when the response rates were at standard 20, 30%, that we go from 20, 30% to 85, 90%, and that's the standard now. That's going to be incredible because the standard is now set so high for drugs moving forward in the clinical trials. It has to get even better than that.
That's really awesome. Other questions?
What is the length of treatment of the new therapy, and how long is the course of treatment?
It's a great question. So I think there have been several, as Craig mentioned, there's a few new options that have been FDA approved. There's also there's a few similar drugs that are also still in clinical trials. So there's several versions of these, antibodies that have two sticky ends that bring the T cells up to fight the myeloma cells. So different schedules are being worked on that are specific to each of the drugs. I don't think we really have sorted out when to stop. I think it's a really important question that we need to look at very closely. These drugs are powerful. I think some of the issues with them when we start them, because when we force the myeloma cells and the T cells to duke it out, and it can be a pretty big brawl, and people can get sick from the fight. I mean, it's like kind of have symptoms mimicking a big infection where people get fevers and chills, and you kind of have to calm the immune system down to make sure it doesn't overreact. And that's what happens at the start. I think after that smoke is cleared from the fight, and hopefully, there's no myeloma cells really left around to fight, or very few of them, and people are kind of on this ongoing treatment, generally, for at least the BCMA bispecific antibodies, symptoms, there's not too many side effects from the drugs, which is great. I think the other challenge that we see with longer and longer treatment is the other downside of these drugs. So people can get infections because either we've wiped out too many of the normal plasma cells and the myeloma plasma cells. People with myeloma are prone to infections from the start because it's a tumor of the immune system. When you fight the immune system, you have risk of infection. So risk of infections is a problem with these drugs. It's an issue that we're seeing that we need to take very seriously. And I think that ongoing treatment in an indefinite way with these drugs carries an increased risk of infection just with time, any of them. Some have more potentially risk than others of infection. Some have less risk. But I think there's a compelling need for us to study the right approach of how much drug to give is enough to get rid of the myeloma, and then we need to figure out how to stop. And that's a really important question. It's going to take a while. Lots of these drugs are coming out all at the same time. It's going to be kind of complicated to study, and it's going to take time. How do we study that? I mean, we give patients, you pick a schedule, you try to get patients to a point where their myeloma is not detectable, and then you try to stop and watch and see what happens. And that takes time, and I think forethought. I think the good news is we've got a lot of new options to treat patients and hopefully get patients into remission. We know to be worried about infections and to watch patients closely. There's certainly many patients on the trials of these types of drugs who got infections and had to stop, and their responses continued for a while. So there's at least some preliminary results from the trials that have already been done that we may not need to give these drugs forever and to get good results. I think we need to figure out how to get in and get out. Use them, then stop them. I think that's the next phase of, as soon as we have this full portfolio of drugs, that's really the next big question I think we need to sort out that's most important for patients.
We have other questions.
Hi, good evening. Prior to my husband's diagnosis, I had never heard of multiple myeloma. I'm not in the medical field. But it seems as though, I don't know if I'm hypersensitive to hearing that term or that diagnosis, that I'm much more aware of famous names in media, in Hollywood, in politics that are being diagnosed with it. So is it that I'm hypersensitive and I'm hearing it more, or is it, do you see an increase of those being diagnosed with multiple myeloma? And if so, what do you attribute that to? Environmental or hereditary?
Philip, you want to talk a little bit about the incidence of myeloma and potentially some of the causes?
It does seem, if you look at the US SEER data for the estimated number of cases for this year, it's about 35,000, of which a third will, be affected by their disease and not live because of their disease. Not third of the incident number, but the overall number. It clearly is a large number of patients, now a large number of people who are being affected. Why is it that we are seeing patients with multiple myeloma more now than before? It's perhaps a number of different reasons, not just one. The first being early detection. We are testing for these monoclonal proteins much more frequently than we did in the past. Many times, if you go to a primary care physician's office, inevitably when you're 45 or you reach a certain age, you get a colonoscopy or a mammogram, you get a PSA at a certain age, etc. In like manner, not uncommonly we've seen MPEV or a SPEP or whatever you call, your lab calls that protein assay being checked. Or if there is somebody who has a neurological disorder and the neurologist needs to do a set of tests to figure out why this person has a neuropathy, and M protein evaluation is part of it. So that's one reason why we are ending up seeing many more patients with these monoclonal disorders. The second is, undoubtedly, we are living longer. And that is good. But we have to keep in mind that the greatest risk for cancer is age. It's not politically correct to say that, but we age from the day we are born, right? And we have to be aware of the fact that we are constantly breaking down and rebuilding ourselves all through our lives. And it's going to be important for us to keep that in mind, because when I am 90, I hope, and I get a cancer, I most likely will, I will be less able to handle it, my body, than if I were 50 and had it. Then the other things are there any particular causations? Viruses, for instance. Nothing classically unlike, say, lymphomas. Could there be exposures? Possibly. Could there be a familial predisposition or an ethnic? And we know about that there is. All of those also will play a part in why we're perhaps seeing more of this. Last but not least, there is, and rightfully so, more press. When I say press, it's not necessarily in the front of the Rolling Stones or the New York Times, but conversation around a dinner table, or in social circles, or in meetings in the hallways of different corporations, or in meetings like this, that we get to be more aware of myeloma.
The other piece is this room. It's all of you are living longer and longer and longer. And as you get new people with the disease, and the people who still have the disease are still around, there are more and more people to talk about this. The second thing is advocacy. When the Myeloma Foundation got started, it was about advocacy. No one was talking to each other. No one was developing these drugs. And this foundation got put together for advocacy, for people to get together to get drugs. And that's how it started. And now people understand, if you are heard, you make us think and say, hey, don't think of me as an orphan drug. I've got to do something. People get involved. You raise money for events like this. That's how things change. And that's one of the most important parts of everybody being here is advocacy to make sure that everyone else is aware of this disease. Please.
And I think that advocacy is really just, at least our foundation has found that just by bringing people together, you know, you begin to remove the stigma, you begin to find camaraderie and companionship in this. And we've always continued to participate in that. And again, I want to thank people for participating in that. On a technical side, I just want to expand a little bit on some of the themes that are described here. The rapid approval of new drugs, the fact that there are now in the neighborhood of, 12 plus different drugs. I guess, yeah, these two more were in the neighborhood of 14, 15 different options. And one doesn't have to be a mathematician to see that you cannot just keep trying to combine these. And for those of you who've gotten 3 or 4 drugs at a time, you can imagine also that just putting all 12 into one cocktail and getting that might be very difficult. So we really need rational scientific approaches to understand what to combine and when, and should it be in newly diagnosed, or do you save that for later? Like, there's an enormous amount of science and intellect going into this in these teams to support that. And I think we have to keep that in mind, because as Matt and others describe this brawl between the tumor and the medicine, the tumor doesn't stand still, right? It is fighting back directly. It is running and hiding. It is putting up new defenses to avoid the therapy. And so by participating in trials, you help us to learn, why did this actually come back? And maybe how can that inform the next choice for you, or the need for an entirely new medicine because of the defense that the tumor puts up. So again, this is just like a back and forth community of doing research, and I just want to highlight that.
Terrific. More questions out there?
Yes. First off, thank you so much. It's amazing to see such an awesome group of experts on the field together. Thank you. My question is just, we've gotten a lot of people in these CAR T-cell trials so far. Do we have any idea on numbers? How many have actually gotten a CAR T-cell, say, in the U.S.? Are they only the clinical trials? And what kinds of numbers are they, like 200 people at a time? Just to get a sense of
Joe?
how far we
So
gotta go.
right now, there's 2 commercially available CAR T cells that are available for patients who fail 4 therapies. So they're readily available for patients who meet those requirements. There are 2 companies that manufacture these CAR T cells. So there was a little bit of difficulty with the initial receiving slots to get these cells manufactured. But right now, if you meet the criteria and we get insurance approval, unfortunately, these therapies are very expensive. So we need to get insurance approval, which sometimes can be difficult. The CAR T cells that we buy, we talked about the cost. And although I hate to bring up costs, we have to think about this a little bit. A CAR T cell is about a half a glass of water, and the companies charge us $500,000 for that. So, and it doesn't include the cost of giving some chemotherapy along with that, some of the hospitalizations, some of the therapies we have to use to prevent some of the toxicities we heard a little bit about. So there's a lot of issues that somewhat delay the use of CAR T cells. Number one, it's the insurance approval. Number 2, it's a manufacturing, which sometimes can take up to 4 to 6 weeks. So there are some downsides to trying to get CAR T cells, but they can be very effective. How many people are getting it around the country? It's probably in the thousands right now are getting it. Again, just at my center alone, we've done 60 this last year. Not all multiple myeloma, but that's how many we've done. So, and the interesting thing, so one of the downsides of CAR T cells says, well, if you have a bifunctional antibody that Dr. Kohler, Dr. Pianko, Dr. Yi can pick up off the shelf, why don't we use that? It targets the same BCMA antigen as an example. It doesn't require some of the manufacturing. So there's pluses and minuses for all those types of therapy. So the physicians involved in taking care of all of our patients has to figure out what's the best therapy for our patient. They may be targeting the same molecule, the BCMA molecule as an example. One may be easier to get than another. They're all incredibly expensive. somebody asked how long do you take CAR T cells for? It's about 15 seconds to administer the CAR T cells. So after that, hopefully you don't have any therapy for a year or two, which is about the average right now for most of the CAR T cell trials. So there's a lot of complicated features in getting these to the patients, which unfortunately hamper us getting to the patients right away. Not the least of which is the cost to all of us to give these and administer these drugs.
Additional questions?
Hi, I'm a multiple myeloma survivor, and I also have, was diagnosed with AL amyloidosis, and I'm doing well. I had Cyborg D starting out, then I had a stem cell transplant, and did some maintenance therapy. I had Ninlaro for a couple years, and then I transitioned to Revlimid and Dara, and now I'm just on Dara, once a month injection. Just wondering how is the progress going on Dara? I know that was in clinical trial when I was first diagnosed. It seems like it's very performing very well for patients nowadays.
Yeah, thank you for this challenging question. AL amyloidosis actually is very rare. Multiple myeloma is already rare to begin with, and AL amyloidosis is even more rare compared with the multiple myeloma. So I always explain to my patients these two diseases are almost like a sister diseases. They share some of the common features, such as the protein production from the body, and then they can damage the body, but in different ways. Because amyloidosis is more some of the bad proteins, they misfolded and deposit onto the organ systems and causing the damages. I said it is challenging because currently most of the treatments that we are offering to patients are to reduce the production of those bad proteins. But whatever proteins already deposited like onto those organs, it's hard for us to get rid of it. So in order for us to improve the organ system, function, this is a big challenge. Now, we do have some clinical trials right now trying to address this question, but it is still in the stage of drug development and not approved yet. So hopefully that could be, that stress the importance of clinical trials if we are able to get more drugs approved for amyloidosis. Another challenging part for amyloidosis, I'm looking at it, is we oftentimes assess the response for the treatment to the treatment, and we once those damages are done, we have to follow those organ functions. For multiple myeloma, most of the time we follow those markers in the blood, and you check those blood work after each cycle and assess the response, and also at the same time assess for the toxicity. But for amyloidosis, it's more challenging because there are multiple organs can be involved. For example, the heart, the kidney, GI system, the food pipe, in the liver. Sometimes it could be in the lung or the skin. So there are so many different organ involvement. So the management for amyloidosis is also quite multidisciplinary approach that we have to apply and involve different specialty doctors to help with the treatment. So you can imagine amyloidosis patients, oftentimes the diagnosis, relatively speaking, could be a late diagnosis because the presentation could be vague. Like if you have any nausea, vomiting, the first thing that your doctor, your primary care doctor would think of is not amyloidosis. This is at the bottom of the we call differential diagnosis, meaning the menu of different diagnoses that we can think of for the presentation of nausea, vomiting, for example. So, and also same thing for the heart failure or conduction problems in the heart. A lot of times the patient presented with shortness of breath, that type of symptoms, and the doctors will look at how to make the diagnosis. And again, amyloidosis usually is not the first thing on the top of the list they would think of. So because of those reasons, the presentation is not not immediately we can think of this diagnosis. So the diagnosis could be late, and also by the time you make the diagnosis, it could be a challenge to treat the patients. But I'm so happy to hear that you are getting the appropriate treatment, and also sounds like you're getting into remission. So I hope we have, yeah. We really hope you stay in remission as long as possible, and with the new drugs coming along the way, and that can help you further along the way. So take care. I feel like every time when I do this type of talk to our patients, our goal, as our panelist mentioned earlier, our goal is not just to treat your myeloma or amyloidosis. Our goal is you can live well. And even though you can have this chronic disease, but hopefully you can achieve remission and live well and spend quality time with family members.
Thank you.
You're welcome.
I think one of the byproducts of all these treatments is that they're also very expensive. And as you get more and more expensive treatments, then it comes with its own problem, which is access to care. And I don't know if any of the people in the audience want to talk about some of their stories they've had with access of cares, or some of our panel members want to address some of the issues that they have when they know they've got a good treatment for a patient, but they can't get the patient's treatment. So maybe, Craig, if you want to start, and maybe we'll see if we can get some people from the audience.
Yeah, I worry a lot, and my wife knows this, because I wake her up, I'm like, I'm worrying. And one thing I worry about is, as I always imagine, the lady in the thumb of Michigan with myeloma, and a lot of what I do when I advocate for patients, I always kind of imagine someone who doesn't have access to the medical centers and the fantastic drugs that we talk about. I mean, I have two people that travel 2 hours every week to get treatment at our center because the access isn't available for some of these fantastic drugs. But a lot of centers can't afford these medications, and a lot of places now require such expertise to deliver it that they can't deliver it. And I always worry about that person up there, because when I say up in the thumb of Michigan and in downtown Detroit, because access isn't equal to these drugs. And when we talk about, the cure for myeloma, that we're curing myeloma, I mean, we are moving in that direction. But I always tell our fellows and our trainees that you haven't cured anything till you have cured everybody with this disease. And I think what we need to really do is find a better way, to a more expertise way to treat. When you talk about daratumumab, when Dara first came out, it required these really long, infusions. It took a day to 2 days to be able to give it. And it was very difficult, very expensive. And I had people traveling hours to receive that drug when it first came out. Now, there is an injection under the skin. I mean, you walk in, you get an injection like you get a flu shot, you walk out the door. And the time span that took was relatively short. I think it was like 5 years to go from IV to being able to give it basically on the fly. These new drugs that we need to expedite having those drugs available to every community that is out there. The thing that always kind of bugs me is that we've talked about, one of the famous headlines is that survival is better when you are being taken care of by a myeloma doctor. And I look at that as what is a challenge of how we as myeloma doctors need the community to understand all these fantastic things that are happening in myeloma. So everyone's getting the same therapy. Everyone has access to those drugs, and everyone sees the benefits of what we see at the academic centers. And that is really when I go out and I talk to anyone that will listen to me about myeloma, so people can learn how to treat this disease and be as excited as we are.
I'm on 31 drugs a day. I have 5 different doctors that like to write notes to each other. They don't put it in the charts. Because of this, I have diabetes, congested heart failure. My kidneys are ready to shut down because of all of the pills. What can I do as far as getting these doctors to talk to each other?
You know, I think that's a pretty fair question and a pretty fair thing that you can ask your doctors. And sometimes what happens when we give drugs, we cause a side effect with the drug. And then the tendency is to say, okay, we need to give you another drug to fix the side effect. And then you get another drug, gets another side effect, and then we give you another drug to fix the side effects. Sometimes it's sitting down and what you're really suffering from is too many pills. And it's getting all the doctors together and saying, hey, who's going to be the team leader? Maybe we can get rid of some of these drugs that are starting to cause the side effect. Is there a more efficient way to manage what's going on? And usually the oncologist, since that's the primary thing that's starting this, is often the team leader for this. And sometimes it's trying to get everyone in the same room. Sometimes we have to have a case care conference where we get everyone in the room and start making phone calls and saying, hey, what are we really doing with this?
What I did was I stopped my treatment for 2 months because they wanted to put me on 4 more pills, which would have made that 35. And I went to each one of my doctors and I said, you guys are writing notes to each other instead of putting it in the chart where everybody can read it. Henry Ford's is not that way. I can look and see when my daughter was born, and it has everything there. I had to tell them one by one that I will subpoena you. And then they all got together. And that was the only way that I could get them together. But it still does not help my situation with the kidney failure, the heart failure, the diabetes, congested heart failure, AFib. Because of the prescriptions, they want to put a pacemaker in, and they're giving me until the 23rd of October to make the decision. But I had none of these problems until I got up to 31 pills a day. And now you're putting a patch on top of a patch on top of a patch. And that's not what I'm looking for.
I think you've highlighted what the problem with all this is, which is as we're getting good treatments, we still haven't cured anyone yet. And what we really need to do is get treatments that are cured so then you can stop all the treatments. Until that day's coming, we got to keep putting patches on, keep things together, and see if we can't do things to make you more comfortable through this. And I think your advocating for yourself is really, really important. And hopefully your doctors will continue to advocate for you to try to simplify things and make things a little bit better.
Using insurance that's paid for 11 years of multiple myeloma treatment very successfully. I'm really curious what you see with people that transition to Medicare and if CAR T or treatments in that vein become an option for him. is Medicare granting approval? Are they paying for that?
Well, in terms of CAR T cell, they're kind of paying for that, and that's the problem. The cost of these therapies are tremendously expensive. So just give you an example of CAR T cells. Some of the Medicare reimbursement doesn't even pay for the cost that we have to pay for the CAR T cells. So they cost us $500,000. Medicare reimburses us $250,000 in some cases if we do it as an inpatient. So the only way we could get reimbursed a little bit better if we try to do it as an outpatient, which we try to do in some patients. So there is a way to try to minimize the loss, and every hospital has to face this. You know, no hospital can survive if they keep losing money on every patient. So it's a difficult thing. I think Medicare is very short-sighted in this. They need to pay for these therapies. They're all very effective. They all provide benefit to patients. So to not pay effectively for us to use these drugs is really a hindrance to bring this therapy to our patients. So this is a fault of the Medicare system. Can I change that? No. We have a society have to change that, and how to figure out to pay for these equitably so everybody can receive these drugs. And it's not only the more difficult drugs, even the outpatient chemotherapy, Revlimid, costs some patients an arm and a leg. If you have a high copay for Revlimid, you might be paying $3,000-4,000 a month for Revlimid. It's something that we have to find a way to resolve, I think, to provide the best care for our patients. So I don't have an easy answer for you on this, and it's just a problem with how our medical healthcare system is. We have to improve upon that. I think it's effectively hurting our ability to treat patients in many, many ways. And how to overcome that takes an act of Congress or an act of God, which is ever easier these days. So that's what the problem really is. We have the ability to give you these drugs very easily, but we have to find a better way to get reimbursement, not only for us, but a better way to avoid the financial toxicity patients have paying for these drugs. That's really what we need to do. And I don't have an easy answer for that. That's a national healthcare policy change that we have to advocate for. And I think people with cancer are the ones who are hurt by this more than anything.
One of the biggest problems with Medicare is it's a system that was designed to take care of patients in the hospital. It really wasn't designed to take care of people as an outpatient. So one of the biggest holes that you have in Medicare is your prescription coverage for it. And so the prescription coverage that you have with Medicare doesn't exist unless you have a supplement or unless you've rolled into some kind of Medicare Advantage plan. And when they put these plans together, most of them have done a great job because they cover 80% of what your prescription drug is. So if you're buying something to treat your cholesterol that costs $20, 80% of that's pretty good. Most people can afford it. When you're looking at some of the oral chemotherapy drugs that we're doing, they're $20,000 a month. Well, now you're getting into $2,000, $3,000, $4,000 a month to pay for the drugs. That's starting to be a hard thing for most people to do. So what the drug company's done to help out with this is most of them have some kind of prescription copay assistance. But unfortunately, the government has decided that if the pharmaceutical company helps you and you have Medicare, then that's an inurement, and they're trying to trick you into using their drug. So they've outlawed for the Medicare patients to actually use these copay assistance cards. So to get around that, what we have is we've got foundations, and the pharmaceutical company donates to these foundations, and then we apply to get a grant to pick up the other part of the drug. So we play this game all the time for getting people drugs and medications. And for most people, we're able to eventually fund it and do it, but it makes it much more difficult to do and a lot more hurdles to jump through. And I know we've got a bunch of people from the pharmaceutical in the back. I don't know if any of them want to comment about their frustrations or things they want to do. A brave one, maybe?
I think I'm where the young lady in the back is talking about Medicare. My Revlimid would cost me $220,000 a year. And I have a grant that takes care of everything. And it doesn't cost me anything for the Rivermed.
Matt, you want to make a comment about patients with access and what you've had to do to get people drugs?
Yeah, I think this is one of the biggest problems we face. It's one that has probably one of the most challenging solutions, involving societal change, legislation. I think that really the challenge, I think, is how do we get the patients the drugs they need in a way that is, not financially harmful to them. I think these patient assistance programs are, I think, essential to what we do. It's an incomplete solution. It's a Band-Aid, and I think there needs to be further, change to try to help whatever we can do to try to make the ends meet so that patients can get the benefits of these treatments without, necessarily, without having financial harm from it. So it's a really hard problem. I don't know the answer. I wish I did, but I think we all have to come together to try to sort out how we sort this out. And I think there's some changes in the future. I think, and I may not know all the exact details of this, but I think there's been some out-of-pocket maximums that have been instituted as, I think, nationally, I believe, for some of the maximum out-of-pocket costs for prescription drugs that'll kick in, I think, next year. Which I think will at least help, especially some of the patients who have very high copays. I think also recently announced that Medicare can negotiate drug prices for a certain number of drugs. There's about 10 drugs in that list. Unfortunately, no myeloma drugs in that list. But I think that there are a number of things that are looking at ways we might be able to try to solve this problem. But it's a very hard problem. But good news, lots of new agents to use. I think we just have to figure out how we as a society figure out how we bridge this gap. And it's complicated.
I don't know where the mic's going. The other problem we've been having is patients pass away, have large stocks of these drugs, and can't give them to anybody. Here's $15,000 sitting there, but nobody else can use it. They've come to me and said, Mary, can you find somebody I can give this to? But they have, patients have to sign something saying they won't get it anywhere else, something to that effect.
So there are organizations that are coming together.
That are taking
I got